The world has changed and it's not slowing down. With 60 years of wisdom, business savvy, and life experience, I've learned how to face change head on with resilience and persistence. And as a committed and very successful coach, I've helped hundreds break through what's holding them back and build the mindset that drives success. I'm Terry Yoffe, and if you're ready to create change, it starts with changing yourself. Let's start a conversation. Every podcast episode will challenge your limiting stories, push you to take bold steps, and inspire you to live the extraordinary life you were meant to have.
Find out that most of my patients who are severely obese are professional dieters. In fact, they do not overeat. And in fact, it's the expression of their gene, their variant of the obesity gene in this environment that causes them to end up being morbidly obese.
Do you look in the mirror and wonder why the weight won't budge, despite not overeating? According to Dr. Lael Forbes, a bariatric surgeon and trailblazer and specialist in the world of weight management, she says it may not be your fault at all. She reveals how the obesity gene plays a powerful role, why weight management is so deeply misunderstood, and how breakthrough medications are transforming lives. In a nation struggling with record obesity rates, this conversation could change the way you think about weight and about yourself. Welcome. Today, I have a very, very special guest. So we've all heard of the words Ozempic, Mounjaro, Wegovy, and the other similar meds. And what do all of these have in common? They are the many injectables for weight loss. And we have so many questions and concerns about today's products. We have Dr. Lael Forbes here, who is a surgeon and specializes in bariatric surgery and has been a trailblazer and specialist in the GLP-1 and GIP for the past 15 years. Today, she is going to talk to us about the pros, the cons, and everything else in between. Welcome, Dr. Lael Forbes.
Thank you, Terry. I'm glad to be here, very glad to be here.
What I like to do is to start by saying, let's pull back the curtain, because people look at you today and they don't know there's a backstory. We all have a backstory. So just tell us, not a novel, your backstory and what your struggles, what your challenges were that actually brought you to today.
The best way to describe it is I was raised by two physicians, so I really experienced, I would say, the golden era of medicine in the United States. They were both professors and had their own private practice. It was the best of both worlds, and they were fantastic physicians. And meanwhile, I had my own way of charting my own course towards becoming a physician. So there were several challenges for me to even become a physician. One, most importantly, I did not appreciate my high school. And so I found a solution, which is a little unusual probably. I took off at 17 years old and ended up finishing my schooling in South America. I then came back and in a very roundabout way, managed to get myself into medical school. And it was very clear from the beginning in medical school that I was essentially born to be a surgeon. I am a person who wants to find a solution and very much enjoys the fixing of problems. And so I started as a general surgeon in general surgery training, and then opted for a subspecialty in weight loss surgery, bariatric surgery, because of my extreme interest in obesity medicine. It's a field that is, even back then when I was in training, I knew was going to be expanding rather than contracting. And I always have wanted to be at the forefront and in an expansive field that kept me engaged. And I would have a sense that could help people in a dynamic and up-to-date way. So that's why I chose weight loss surgery.
Here we are today. There are so many pros and cons about all of these medications for weight loss and what's behind these medications. And then we're going to get into the whole obesity problem in this country, because I'm going to guess America is probably the number one country for obesity.
Unfortunately, it absolutely is. We have an obesity crisis in our country. 45% of Americans, as of 2024, are known to be obese. That would be a body mass index of 30 or greater. And there are about 60 plus million Americans in the severe obesity category. That means a body mass index of 40 or greater, or at least 100 pounds over their ideal body weight. We have a crisis and an application for surgical treatment and an application for medical treatment of obesity. And as a surgeon, I always wanted to have in my armamentarium more than just a surgical solution, because I knew that when we talk about obesity, it's a complex multifactorial problem. And so certainly surgery cannot be the end all and the be all and the one fix for this problem. And indeed it is not. So I began to look into what could be done for patients who either do not qualify for surgery, and very importantly, for patients who have had weight loss surgery but are need more help in the terms of their insulin resistance, and I can explain what that means, but also in terms of further weight loss after surgery. So I began to explore this back in 2009 when I was at the University of Rochester, and I was in the presence of very bright and innovative other physicians and doctorate researchers, and began to realize that there was a class of medications that really could help patients lose weight, in addition to helping with diabetes and prediabetes.
When we talk about obesity, I know that there is a percentage that could be genetic versus overeating. How do you understand that, and how do you move forward with the genetics versus anything else?
I think, Terry, the best way to understand that is that indeed everything is genetic. So everything has a genetic basis. It depends on the variant in terms of our genes. So we know there is an obesity gene. And when I say that, I mean a polygenic gene, meaning it's not something that we can just pinpoint and target right now with the kind of sequencing technology we have. It's going to take the next generation of sequencing for us to be able to actually find a marker for the obesity gene, because there are many variants. So you take a patient at age 40 who presents to me severely or morbidly obese. In other words, body mass index already greater than 40 or greater, I should say. They have a different kind of genetic background than a patient who presents to me at the same age, same gender, same cultural association and exposure to in terms of the environment. And they may present with a lower severity in terms of their obesity, more in the range of BMI, body mass index of 30 to 40. We cannot say that that's entirely the environment or overeating. What it is each of those patients has a different genetic background, and in the same, what I would call obesogenic environment, which is our modern world, especially in the United States, their gene is expressed differently. So it's not that one patient overeats more than the other. In fact, it's quite interesting to find out that most of my patients who are severely obese are professional dieters. In fact, they do not overeat. And in fact, it's the expression of their gene, their variant of the obesity gene in this environment that causes them to end up being morbidly obese.
When somebody comes in that's not overeating, so you're not looking at eating as a factor, yet something deeper, how you would work with somebody like that where eating isn't a problem.
Well, I can say when I say overeating is not typically the problem, what I mean is it's not that they typically will ingest too much food. It's just that our food now, the environment that we are in is a so-called obesogenic environment, meaning it promotes obesity. Why? Because of we've all heard this before, the over processing of our food, the high content of over processed, highly concentrated processed sugars that all add to the problem that is based in genetics. So I do not assume when a patient is either obese or severely obese or simply overweight that they have an eating problem. It's simply their gene has expressed itself as it has in this environment. And so I'm not saying I'm discounting nutrition. We do need to know how to best eat for our genetics within this environment that we live in, which basically promotes the wrong kind of eating. But I never approach the issue of obesity as if it were the patient's fault, as if they were just not doing the right thing somehow. They were overeating or not exercising enough. That's not the case. And that's been disproven now. We know it is not a case of overeating and just not exercising enough. It really has to do with their genetics. And right now, since we can't even find these variants in terms of markers, all we can do is try to get around the genetics with the excellent modalities we have, which are surgical weight management and medical weight management with these novel, revolutionary GLP-1 and GIP analog medications.
Tell us about GLP-1 and the GIP and these injectables, because I personally have heard pros and then cons. Well, if you're thin, why do you need to continue taking them? I mean, look at you. I take myself. I do take something. And people look at me and say, my God, you're so thin. Why are you taking them? They're bad for you or they're not. So dispel all of these so-called pros and cons.
There are quite a bit of misinformation out there about what these medications really are. And perhaps it starts with the definition of what they are. So, for instance, let me give you an example of another kind of problem that is treated with a similar type of medication. So if we have a thyroid issue, in other words, if our thyroid is not functioning properly and it's diagnosed and our endocrinologist, our primary doctor, our internist diagnoses that we have low functioning thyroid, typically we will be prescribed a hormonal replacement of thyroid hormone. And typically it's synthetic hormone replacement medication that is not injectable. It's typically oral. What's happening though is that we are adding to our bloodstream more thyroid hormone. It's just that it's a synthetic analog to thyroid hormone. And so we have no question about the fact that most likely we'll need to take that medication the rest of our life, because if we stop taking it, our thyroid is going to go back to not functioning properly in the sense of not producing enough thyroid hormone. And so we'll have the same symptoms we had to begin with. So if you think of GLP-1 and GIP medications as really hormonal replacement analogs, what's a better term really? A way of increasing the amount of these two hormones called GLP-1 and GIP, and therefore allowing our bodies to lose weight in addition to lowering our insulin resistance. And what are these GLP-1, GIP medications? Or what are these hormones? They are hormones that are produced by the intestinal tract It's a very complicated mechanism, but are very important in why we are insulin resistant, meaning why we can develop pre-diabetes or diabetes, and why we will become obese regardless of what we eat. Again, not overeating, just simply maybe making some choices that could be improved, but more it's about our genetics. And our genetics are that we are most likely not producing enough GLP-1, GIP, much like with the thyroid deficiency, we're not producing enough thyroid hormone. So again, why would we need to take them the rest of our life? Just like with thyroid hormone, if we don't take these hormonal replacement medications, GLP-1 and GIP medications, we will likely go back to where we were in terms of our insulin resistance and our weight, our tendency to carry extra fat mass.
Dr. Forbes has more to share, but first, a quick word from Try Coaching. Are you truly living your best life or someone else's dream for you? Far too often, I work with clients who feel unfulfilled. When we dig deeper, they realize the path they're on was never their choice. It was the life their parents, society, or others expected. If you feel stuck in a life that doesn't feel like yours, it's never too late to change. I've helped countless clients and myself rewrite the story and step into a life that finally feels authentic. So, if you're ready, let's start that conversation. Now, back to the podcast. At the beginning, I talked about Ozempic, Mounjaro, Wegovy, Zepbound, and probably there are others. Is there any difference in each of these medications? And how would somebody, for those that don't know, how are these gotten into the bloodstream? We know they're injectables. So talk a little about all of that.
Okay, so the names get a little bit difficult to sort out because you're talking about are brand names of two different medications that are in the same class. They are incretin analogs, okay? What do I mean by incretin analogs? That's what GLP-1 and GIP hormones are. They are incretin hormones. They are hormones produced by the gastrointestinal tract. So, first of all, the one we know about probably the best in the world is Ozempic. Ozempic is the brand name for the first incretin analog medication that is injectable on a weekly basis called semaglutide. So it became so well known because, number one, it was now able to be injected only once a week and gets into our bloodstream readily in order to correct our insulin resistance, improve our insulin resistance, and miraculously interact with a receptor in our brain to help reduce our tendency to want to eat the kinds of foods that are obesogenic, that are all over widespread in our lives today. And that's what I mean by obesogenic environment. We are exposed to such a wide variety of very fat-inducing foods. So foods that cause us to store excess fat. So Ozempic is the first brand name of semaglutide, a very effective GLP-1 analog. Fast forward, it was found to be so effective to help patients lose weight. When I mean weight, I mean lose excess fat, that it was then approved for weight loss alone without having to have prediabetes or diabetes. In other words, not having to have any evidence of insulin resistance. And it was branded a different name called Wegovy. So Ozempic and Wegovy are the same medication, semaglutide. Fast forward, then we had a new generation of GLP-1 medications called GLP-1 GIP medications. In other words, we added the analog to another intestinal peptide called GIP, which also has a lot to do with insulin resistance and our eating behavior. So now we fast forward to tirzepatide, which is branded as Mounjaro, which all of us know, which was first branded for the treatment of type 2 diabetes, insulin resistance. And then again, 2 years later, was found to be so effective for obesity to help patients lose extra fat mass without having any prediabetes or diabetes, that it was rebranded as Zepbound. So you can see it gets complicated because each medication has two different names and they're just a different generation. They're both effective. So it's not that semaglutide's not effective. It's just that tirzepatide is more effective than semaglutide because of the addition of this other intestinal hormone, GIP.
There are probably a lot of people that think about these injectables, except they are out of reach for them, meaning it's not easy to get on a program with them and have it be covered by an insurance. I mean, without insurance, it's costly. And of course, it's being costly, it's not available to everyone.
Yes.
What are the markers that insurances look for when they go to a doctor like you and you examine them and you go through all the testing and you know they need it?
So access to insurance coverage for these injectables, these weekly injectables, meaning they only need to be injected once a week, although we can vary the interval and expand it past once a week or even shorten it. Access to this class of medication is difficult because they are expensive. So health insurance industry in general does not want to cover expensive medications unless the patient meets criteria as per FDA approval. So for the brand names of the two different medications that are available right now in terms of weekly injectable, that would be semaglutide and tirzepatide, branded as Ozempic and Mounjaro. What the insurance companies are looking for is the biomarker hemoglobin A1C. Okay. So a doctor like myself has to either prove that the patient has had a hemoglobin A1C level at a certain point that would give them the diagnosis of type 2 diabetes, or if they have come to me already on a different class of medication, an oral medication. Typically everyone knows that the name metformin, which is a very basic medication for type 2 diabetes. Therefore, they come to me already with their hemoglobin A1C marker lowered below type 2 diabetes, but their internist or endocrinologist or PCP, primary doctor, has diagnosed them with type 2 diabetes. Typically, they will be covered. Now, those are the two brand names for semaglutide and tirzepatide approved by the FDA for type 2 diabetes. Now, this makes it even more confusing because, of course, semaglutide was branded as Wegovy for weight loss. So what is the marker insurance looks for? Body mass index of 30 or greater, that would be obesity, or overweight, be it body mass index 27 to 29.9 with other medical problems associated with obesity. And typically, I can get those medications by documenting properly what the medical problems are that the patient has, if they do, that are associated with obesity, and what their body mass index is. Same for tirzepatide. Tirzepatide has been branded as Zepbound for obesity. So the same criteria, the body mass index 30 or greater, or 27 to 29.9 with at least one medical problem associated with obesity. Now, I know that's a lot, but I have to say there's news with regards to tirzepatide, specifically branded as Zepbound for obesity. Thankfully, the FDA has approved very specifically that brand name Zepbound, tirzepatide branded as Zepbound, for the diagnosis of sleep apnea and now the diagnosis of fatty liver, weight-associated fatty liver, so non-alcoholic fatty liver. So that's expanding a little bit the ability to help patients have access to tirzepatide, which is the most effective by excellent studies published by the New England Journal of Medicine and other publications showing that tirzepatide is currently the most effective FDA-approved medication for obesity and now also for treatment of sleep apnea and for treatment of fatty liver.
We talk about these products as being for weight loss specifically. However, we have had conversations that there is so much more that these medications can do in a very positive way. Please share with us that as well to dispel anybody that are naysayers.
Right. So in my quite a few years of working with this class of medication, names that most people won't even know of prior to semaglutide, the advent of semaglutide. So there were GLP-1 medications that required daily injection, and then prior to that, twice daily injection. So they weren't well known, for instance, for obesity because they weren't applied for obesity. They were applied for brittle diabetics who were not responding to other medications. Well, in all these years of using these medications, I've come to realize, and as the medical community has, that these two intestinal hormones, these little baby hormones they're called gut peptides, meaning they're very tiny peptide hormones, are incredibly powerful, and they have a lot of other effects in terms of what they do within us. So yes, they are involved in our tendency towards insulin resistance, both genetic and as we age. And they're also involved in our eating behavior, but they're also involved in other disorders that are very difficult to diagnose, such as PCOS, polycystic ovarian syndrome. And so they can be applied for that particular disorder, which is very difficult to both diagnose and to treat. They also can be applied for something that's not well recognized, and that is central obesity. In other words, someone comes to me with a BMI under 27, but they're carrying too much central fat, visceral fat, the fat around our organs that can affect our overall health and longevity. So we can apply these medications to a patient who's not actually officially overweight or obese, but I can measure with a body analyzer, for instance, or a DEXA scan. I can see where they're carrying any kind of excess fat, and I can apply the medications for that. I have been also using this class of medication to help with what I would call age management. In other words, along with an analysis of a patient's gender hormones, depending where they are in terms of their lifespan. I will both talk about and implement bioidentical gender hormone replacement, along with low dose or micro dosing of these GLP-1s. Now, this is what we typically would call off-label prescribing, which is absolutely legal in the United States. In fact, many medications are prescribed off-label almost exclusively, meaning that they're prescribed for a diagnosis that were not originally approved for by the FDA. Medication everyone we all know about is minoxidil. Minoxidil is actually a blood pressure medication. It's approved by the FDA for the treatment of high blood pressure. It was never studied for hair loss, but yet it is prescribed almost exclusively off-label for hair loss. So that's what off-label means. It means it's a safe way to prescribe a medication that may not be officially approved by the FDA for that diagnosis, but based on experience and studies, it is shown to be effective for that diagnosis.
One of the things that we talked about that you would like to do is set up a adolescent center for adolescents that are obese, or which we see so much of. And one of the things we again talked about, there's a lot of socioeconomic challenges today, meaning if you're in an economic area system where you can eat well, where you can afford to go to a grocery store and rack up 500 or more on good foods, you have a much better chance of eating well and watching your weights. However, when we get to a lower economic society, that's where challenges can come in, where parents work 2, 3 jobs, and all they can do is go and grab Kentucky Fried Chicken or something like that and bring that home for their children because they do not have the time to cook or indulge in well-prepared meals. And I think you said that 17% of obesity is with adolescents and 27% is in economically challenged households. And here you are, getting back to my original question of wanting to create a center, I believe, for adolescents. I would love for you to talk more about that.
Let's go back to this concept of an obesogenic environment. In general, right now, 2025 in the United States, we are living in a very obesogenic environment, meaning that not just our food sources, but our lifestyles promote the storage of excess fats, which we know can be very damaging to our health. Obviously, we know what some of the medical problems are that are associated with excess fat storage: high blood pressure, high cholesterol, cardiovascular disease, sleep apnea, it goes on and on, joint disease, etc. So the truth is, though, that most Americans are exposed to a more obesogenic environment than, let's say, those living in exclusive urban environments. So patients that come from economically challenged communities, and that can be either urban or rural or suburban, are exposed to a more of an obesogenic environment. So whatever, again, back to the concept that it is genetic at its origin. So whatever variant of the obesity gene they have, whatever variant of the insulin resistance gene, which also has a genetic background that they have, they will express obesity at a greater rate and a greater proportion than patients who are able to gain access to better food sources and to a more active lifestyle. So let's talk about the adolescent community. Well, first of all, they're in the whatever socioeconomic environment that their parents are in, typically. And so they have this unique challenge of not really even being able to find their own way in terms of what kind of food sources they actually have access to. And so they're very vulnerable. So both pediatric and adolescents in socioeconomic challenged communities are very vulnerable to obesity, to having their variant of the obesity gene expressed. Because why? Because they're in a more obesogenic environment. My vision is to support these patients in a better way, both with helping to give them access to a lifestyle and food sources that will lessen their tendency to develop obesity, but also this amazing class of medications that can so effectively help treat obesity if it has already been expressed. Just so you know, very, very importantly, the American Association of Pediatrics has officially approved the use of semaglutide and tirzepatide in the pediatric and adolescent population. Okay. They also have approved very sparingly and with very strict criteria the use of weight loss surgery in this same population in order to treat obesity, because we can prevent the medical problems associated with obesity from happening. A patient will have a better lifestyle and life, and we can improve their longevity, essentially. So why do I think that we most likely have to have at least a foundation that starts in urban centers where adolescents are at the most risk, I think? And that is because, unfortunately, we were talking about how, in general, we have limited access to this class of medication due to their cost. Well, adolescents from socioeconomically challenged families, okay, have even less access. Why? Because typically, if they're on a government-assisted health insurance, obesity medications have been completely excluded from coverage. So in order for them to have access, it's going to have to be the private sector for now, until we can pressure our government essentially to cover this amazing class of medications for patients in socioeconomically challenged communities, and in particular for adolescents, so as to prevent medical problems associated with obesity. So they are the most vulnerable, and I believe they need the most help.
You've said so much. However, if you could give us one or two takeaways for people to think about, and if someone wanted to reach out to you, where could they reach you?
Well, I think one very important takeaway is that if we struggle with obesity, in other words, excess fat storage, and we have typically tried many different ways of addressing it with diet, exercise programs, etc., other medications that haven't worked. The important thing is to know that it's not your fault. It is, again, obesity and insulin resistance has a genetic origin, and it's just expressed differently at different ages based on the variant and based on different environments, whether the environment, how obesogenic your environment is. So seeking help is a good thing, and help is there. We have, thankfully, this amazing, remarkable class of medications that has almost no side effects and is very, very effective. The other takeaway I would have to say is that because these are hormonal replacement medications, they are not meant to be given without supervision. It could be even unsafe for a patient to just, go online and get this medication and just take it with no one monitoring body composition, monitoring important laboratory tests, and very importantly, managing their weight loss program. It is weight management. It's not just weight loss. It's weight management. So it really needs to be in a setting where a patient is properly managed with a physician and a comprehensive program with a team. Okay, a team approach, dietitians, psychologists, etc. Okay, how can they reach me? My main office is in New York City. I do have a satellite office in the Greenwich, Connecticut area, but I'm absolutely able to provide video consultations, and I can be found on my website, which is myforbeshealth.com.
And what about an email? Can they send you an email? Would that be acceptable to you?
It's also a phone number. Actually, it's a better way. So the phone number is 212-304-4331.
Dr. Lael Forbes, thank you so much for all of this brilliance and, of course, all of your knowledge. It's so incredibly important, especially today. Thank you so much.
Thank you so much, Terry. I appreciate it.
After hearing Dr. Forbes talk on weight loss, you might want to change your views on obesity and how you view yourself. Remember, being overweight might not be your fault. Please go to Apple Podcasts and leave a 5-star rating and review. Also, please visit my website, trycoaching.com. What happens when you build businesses, write a best-selling book, sell your biggest venture, then suddenly feel lost without an identity? That's where Marcus Corlius found himself. In this episode, he shares the surprising challenges of life after success and how he's learning to be more intentional with his time, mindset, and resources. Marcus opens up about identity, reinvention, and why his biggest game is still ahead.